Hello, everyone, and thank you for joining our scientific exchange session for this month. My name is Sphere-9ᵀᴹ. I'm the Chief Medical Officer for Cardiac Ablation Solutions at Medtronic. We have a very exciting session today discussing the Sphere Persistent AFib trial, which was recently presented as a late breaker at HRS 2024 and simultaneously published in Nature Medicine. There are many reasons why this trial is important. First, it addresses persistent AFib, a challenging arrhythmia where outcomes have remained suboptimal. Second, in the focal point-by-point field, we have seen little innovation with the tools that we use, and the trial is designed to assess the effectiveness, safety, and efficiency of the Sphere-9 all-in-one map and ablate catheter with dual energy source, both RF and PF. Third reason is nothing better than clinical evidence, and there's no better than randomized clinical trials to provide clean data, and this is the first randomized trial to assess even the role of PF in persistent AFib patient. As a reminder, the Sphere-9 is not yet FDA approved in the US. And today I'm also grateful for the speakers who are joining us today, and they really don't need any introduction. And it's my pleasure to introduce Dr. Vivek Reddy from Mount Sinai, Dr. Elad Antar from Shamir Medical Center, and he was the global PI of Sphere Persistent AFib trial, Dr. Devi Nair and Dr. Musa Mansour. Dr. Nair is from San Bernard Heart Center, and Dr. Musa Mansour from Mass General. Both were investigators in the trial, and they will share with us their experience with the trial. To frame the agenda today, Dr. Reddy will kick us off by providing us with an overview about Sphere-9 and the system itself, including the first-in-human data from the European trial. Dr. Antar will discuss the results of the trial, and then we'll hear from Dr. Nair and Dr. Mansour about their experience with the trial. I want to remind all of our attendees to submit the questions they have using the Slido box on the right side of the screen. And with that, I'll turn it to Dr. Reddy to kick us off. Dr. Reddy.
Thank you very much, Khaldun, for the very kind invitation to discuss this. Hopefully, you're able to hear me okay, and I don't have the mute on, as I sometimes do. So my charge is to discuss and provide an overview of the Affera technology, and specifically the Sphere-9 catheter and some of the clinical evidence leading up to the pivotal trial. So just my own disclosures, and please note, as Khaldun said, the technology we'll be discussing does not have FDA approval yet. First, I want to describe the lattice tip technology, and then we'll go through some of the study outcomes. So let's talk about the catheter itself. So the catheter comes with its own system. So it has its own electron-anatomical mapping system. There's a generator, the hexagen RF generator, which you see here, and it uses temperature-controlled RF energy for the creation of these lesions. We'll talk more about that. There's also the PF generator, which allows for irreversible electroporation. And of course, there's the interface unit. And this allows you to perform electron-anatomical mapping using magnetic navigation. And the expectation is soon there's also going to be electrical impedance-based mapping. And there's also an irrigation pump that you see here, as well as a remote that the technicians can use to control the power, and a foot pedal that the operator can use both to toggle between RF and PF, as well as, of course, to deliver the energy itself. Let's talk about the catheter, because this really is, I think, one of the most unique ablation catheters that's been designed. This is an 8-French catheter, as you see here, coming out of a typical 8.5 French sheath. You can see it's a 9-millimeter diameter mesh, and there's many electrodes on the surface, and as well as surface thermocouples. So each of these can record electrograms as well as your temperature. You can also see it's compressible, as shown in this video, and because of the surface topography, there is some degree of friction, which seems to help in terms of catheter stability. That's the electrograms. What about the energy? The energy is actually delivered from the whole lattice tip, not just the individual nodes. That's true for both RF energy as well as PF energy. You can see that unlike traditional catheters, which have a relatively small interaction with the tissue, the lattice tip has a large interaction. I think the fact that it's a large footprint is one of the most interesting and critical aspects of this technology. There's an irrigation nozzle at the center for both irrigated RF lesion and also irrigating during PF. And it's a bidirectional deflectable system. Leading up to the current technology, which is delivers both RF and PF, in an initial version, it delivered only RF energy. And I just want to show you some of the data. This never really reached clinical practice that is pure RF, but it shows the promise. And the idea, again, is when you have a large tip, you can hopefully concatenate these lesions to make a circumferential lesion set without gaps. And sure enough, that's what we saw. So in the initial clinical trial involving approximately 27 patients, what you see is when we did 3-month remapping studies, PVI durability was extraordinary, 99% on a per vein basis, 96% on a per patient basis, and excellent durability also for linear lesions. And in fact, this translated to really very good clinical success. Again, this is small numbers of patients, but still very good clinical success out to 1 year. Of course, the world changed. We have the concern about damage to adjacent structures, and with the advent of pulse field ablation and minimal damage to the esophagus, the technology adapted. So then instead of just delivering RF, which is what you see here, you can also deliver PF energy. Just looking at this, by the way, what is this? So these orange lines represent thermocouples on the surface, and you can see the maximal temperature here. Again, this is delivered over 4 seconds. This is a 4-second RF lesion. What about PF? Well, the mechanism of ablation is largely non-thermal. So over this, approximately 4-second lesion, you can see relatively minimal elevation in the surface temperatures. By the way, there is some small elevation, and we'll talk more about that. This is also a mapping system. So as you sweep the catheter around inside the chamber, you can render the anatomy as well as annotate electrical information, such as this bipolar voltage map. During the mapping, again, there's 9 surface electrodes and there's a central reference. So what you're talking about is really close unipolar configuration. This reduces far field potential. So you can create electron-anatomical maps. You also have this propagation area. So when the catheter is sitting at any location, based on the timing of the electrograms at the various electrodes touching the surface, there's an arrow that on a beat-to-beat basis tells the operator which direction the waveform is moving. What happens during ablation? Well, there's the sensor globe, which you'll see both on the catheter as well as the central globe. And what you'll see is the baseline temperature, 37, it's blue. When you deliver RF, you see this bright blush of red as you get heating on the surface, which is what you want to see, of course. With pulse field, of course, you don't see this bright blush, but you do see some elevation of the temperature. And this seems to be a relatively good indicator that you're interacting with the tissue and delivering something into the tissue. During ablation, you also have this indicator that shows the distance between adjacent lesions. And you can set that anytime it exceeds a certain distance. So for example, you can say, for example, when 2 adjacent lesions exceed, let's say 6 millimeters, it'll turn blue. That's just a visual cue for the operator to help place the lesions at the distance that they want. What about something as, let's say, simple as a CTI line? This is an REO view here. This is an inferior view as the catheter is being pulled back. And what you see here, one of the really nice things is when you're back here on the proximal edge, because the whole mesh is ablative, even this proximal part is ablative. So oftentimes this region here on the IVC edge, which can sometimes be difficult to ablate, you can interact with the mesh. During ablation, again, after the end of ablation, you put the catheter on the other side, you can see the propagation has gone all the way around. Here you can see it on fluoro. It's also nicely visible on intracardiac ultrasound. So it's easily appreciable when the catheter is touching tissue versus not touching tissue. Okay, so what's the actual clinical data? Well, we did an initial first-in-human series in Europe at 3 centers, and I'll go through those, involving 76 patients. And basically, we reported the acute procedural data where we delivered pulse field posteriorly and RF anteriorly. What we saw was acutely, all the lesions were successful, PVI as well as linear lesions. And the transport ablation times were quite good. And I'll get into this in a little more detail. But then after this, we enrolled an additional 100+ patients for a total of 178 patients. And this was published in JACC Electrophysiology last year. And I think this is a really good manuscript because we cover the whole sort of experience from the acute experience, remapping experience, and clinical outcome. So I just want to spend a few minutes going over this. Excuse me. So first of all, This is a non-randomized first-in-human experience at 3 European centers, but a total of 11 operators, so not a small number of operators. Procedures for under general anesthesia, we use a deflectable sheath in the majority of cases, and intracardiac ultrasound in all the cases. As in all these esophageal studies, PFA studies, there was no esophageal management strategy, no temperature probe to monitor ablation, no deviation, cooling, etc. Here's what we had: 178 patients. You can see 70 were paroxysmal, just over 100 were persistent. All patients received PVI, and linear lesions were according to the operator. The energy delivery during PVI for pulse field ablation was biphasic waveform, and there were a total of 3 different waveforms: pulse 1, 2, and 3. And the final waveform, pulse 3, which was as you'll see, the best waveform, we included a total of 51 patients. It's 4 seconds per lesion. For RF ablation, these are temperature-controlled, saline irrigated lesions, 5 seconds per lesion. And the energy during linear lesions could be either RF or PF. And we separate the cohorts based on the PVI strategy, meaning we could use, for example, the RF-PF strategy, meaning pulse field posteriorly, RF anteriorly, or a pure PF strategy, meaning pulse field both posteriorly and anteriorly for PVI. And here's what they were. There were 79 patients with the RF-PF strategy, 99 with the pure PF strategy. And importantly, all patients were planned for a remap procedure at 3 months. If we look at the acute outcomes, PVI was performed, of course, at 100% of patients, and linear lesions to various extents: mitral line, roof line, with including box lesion, and CT isthmus line. Acutely, all lesion sets were successful using the lattice tip catheter. How was the procedure? Well, I'm going to show you the transpired ablation time, because I think that gives you the best understanding of what was actually done. And again, this is defined as the time from the beginning of the first lesion to the end of the last lesion. For PVI, just over 20 minutes, whether using an RF-PF strategy or a pure PF strategy. And over the course of experience, Pulse 3, it was a little bit faster, about 2 minutes faster than Pulse 1. The linear lesions were also performed with very good transpired ablation times, just under 4 minutes for the mitral, around 2 minutes for the CTI, 2 minutes for the roof line. If we look at first pass PVI isolation, it was very good with Pulse 3, 99% isolation at first pass. Again, ultimately, all were isolated. The acute reconnection rate, that is during the procedure itself, was quite low, and by the Pulse 3 waveform, only 3% acutely reconnected. And if you look at fluoro time, mean time was 4.3 minutes. You notice 0 to 14, so some of these were done completely fluoroless. If you look at remapping results, here's what we see. If you look at durability on a per vein basis, you can see it improved over the course of the experience. By the time we had Pulse 3, 97% of the veins were durably isolated, translating to 90% of the patients receiving all veins durably isolated. And this is similar whether we used an RF-PF or a pure PF strategy. For linear lesions, if we look at the LF roof line, for example, it was 100% durable with Pulse 3. For other linear lesions, we used various combinations of RF and PF, and this still needs to be teased out exactly what's the best strategy. And just for comparison, what you're looking at here is various, the durability on a per patient basis. These are various RF strategies, including point by point. And notice that the lattice step RF, which is the initial slide I showed you, had very high durability. Here you see various single shots, laser as well as cryo. And here you see the PFA balloons, the pentaspline catheter. And here, the lattice tip, including the Pulse 3 waveform, showing that it's quite good. What about safety? Well, if we look at the safety event rate, it was really excellent. Only 1 patient had hospitalization for inflammatory pericardial effusion treated with medications. So that's the primary adverse event rate of 0.6%. There was, I should point out, another patient who had pericardial effusion, and that was during a remapping procedure, and 1 patient with a major vascular complication. What about esophagus? Well, we did do EGDs. And using the RF-PF strategy, it was interesting. There were 2 patients that had minor erythema. And the question was, why is this if we were using pulse field posteriorly? Well, here's what it turned out. Here's an example of one of the cases. What you see is particularly at the left inferior, when the catheter is positioned, even though the goal was to ablate posteriorly, because of the breadth of the catheter, part of it is also touching anteriorly. I'm sorry, let me rephrase that. The goal was to ablate anteriorly, RF, but part of it's touching posteriorly. So what ends up happening is, even though you're trying to deliver RF anteriorly, you also end up heating posteriorly. And once we realized this, then what we ended up doing was changing the strategy so that in those situations where it's relatively narrow, we would deliver PF. Using that strategy, there was zero esophageal issues, and in a larger number of patients using pure PF, so you don't have to worry about this issue at all. Again, there were zero esophageal issues. If we look at clinical outcome for the full cohort, it was interesting. Whether the patients are paroxysmal or persistent, the success rate was quite good. It's about 78% success at 1 year. If we look only at the pulse 3 waveform, and here we're only at persistent. By the time we got to pulse 3, most of the patients were persistent. You can see again the success remained quite good at 85% success at 1 year. That's single procedure success, by the way. Interestingly, if you split it between RF-PF versus pure PF-PF, this is for the PVI strategy, again, no difference in outcome, both around 77, 79%. And if we look only at the persistent patients and separate the pure PF strategy, shown here in green, excuse me, versus the RF-PF strategy, it's interesting. The RF-PF strategy, actually, the patients seem to do a little bit better. But again, this is just hypothesis generating. We're comparing between various groups, and it certainly is not randomized. But it is intriguing that the ability to have a combination of RF and PF might actually afford some advantages, and we still need to understand this better. So what we found from this first human experience is that using either a pure PF strategy or RF PF strategy for PVI, this lattice tip catheter can isolate the PVs and create linear lesion. The wide thermal perforant allows for a highly efficient procedure as well as a safe procedure, very high degree of lesion durability, and promising freedom from arrhythmia recurrence. Now, the limitation from this first human experience was, of course, a small number of operators and centers. But of course, as we're going to hear from Elad in just a few minutes, there's a randomized trial, and we'll see the results of this. There's a lot of interesting areas with this catheter. It's an interesting catheter, allows for other things such as pulse field mapping that is non-ablative lesions, something we need to study further. And certainly, I think there's a lot of potential excitement about its use, not just in the atrium, but also in the ventricle. And again, we need to study that more. And at that, I think I'll go ahead and stop. Thank you very much.
Vivek, thank you. That was great as usual. And I hope you feel better and your voice gets better. I just want to thank you because you really helped all of us learn more about PFA in general, and with the great work that you've done, I think it made all of us a bit smarter, but especially with, I would like to hear your opinion while Elad's getting his slides ready about the knowledge that was built with the remap. If you look at the clinical outcomes for the whole cohort, it looked pretty good, and one could have stopped at that point. So you kind of started that culture of the remap, and if you can just share with us your thoughts about whether this should be, what lessons can we learn about this? And the second, you mentioned about, you showed beautiful videos about the stability of the catheter. These are 4-second lesions and 5-second lesions. If you can tell us more about your clinical experience with the handling of the catheter with that stability feature and the quality of the lesions.
Yeah. So look, if we were not doing remapping studies, what would have happened? Let's look at that. The pulse 1 waveform, by the way, all these waveforms were tested exhaustively in animals. It's not like you just jump into patients, right? Nobody would ever do that. And in the preclinical studies, there was excellent durability with the pulse 1 waveform. But the problem is, animals are animals and humans are humans, and we're treating patients with disease. And when we did the study, as you saw, the durability was not quite good. If we had not done the durability, and I give the company a lot of credit for this. As a small company, it's a big risk to do all that. But as it turns out, it's actually a bigger risk not to do it, because by doing that, we're able to understand very quickly that, look, the durability is not very good. And then the company, to its credit, iterated the waveform to the final pulse 3 waveform, where the durability is not just good. I mean, it's as good as you can expect, I think. So I think the willingness and the company, as well as the investigators and everyone and the patients particularly, to undergo these remapping procedures contracted what otherwise would have been a decades-long experience of looking at clinical outcomes and maybe iterating the waveform to a very compact thing. So then we end up with a technology that was used in the pivotal trial that we feel really, really good about. And then just very quickly to your second point about the handling of the catheter, I'm not sure I fully appreciated how nice it was until we did the first patient. Like even in the preclinical studies, I personally didn't appreciate how nice it was, because when you're moving the catheter in patients and you're able to go to a location, like for example, the roof on the right side, right? I say in the right lesion set, of the right pulmonary veins. That roof region, oftentimes you're trying to balance the catheter, so you're not pushing too hard, so it goes one way or the other, but you're pushing hard enough that you make a good lesion. In fact, the role of contact force, in my mind, is exactly that, to help you optimize the amount of force. With this catheter, it really, you just push a little bit harder, and the respiratory and cardiac motion are just absorbed by the catheter tip. I mean, nothing is perfect. You still have to, have some technique, but I think it just changes the equation in terms of the ease of use, let's say, of the technology. Combine that, by the way, with the fact that it's a large footprint, so that as you're trying to make a lesion set without gaps, it just makes it a little bit easier, I think, significantly easier.
Fantastic. I'm sure more questions to come. And with that, I'll turn it to Elad. Elad is going to share with us the late breaker and tell us more about the study, Elad, and the results.
Great. Thank you, Khaldun, and thank you for Medtronic for this kind invitation. So I'm going to follow on Vivek's description of the technology and present the IDE trial that was just released during HRS, also during a simultaneous publication in Nature Medicine. So you're welcome also to read this paper. And I'm fortunate that tonight, Musa Mansour and Devinir and Vivek Reddy, those are pivotal parts of this study, are joined. So here are my disclosures. Importantly, this IDE study was sponsored by Affera that was later acquired by Medtronic. And the investigational device, the Sphere-9ᵀᴹ Catheter in the system, although it has a CE marked in Europe, it's still not yet approved in the United States. I'm not going to go through the technology. Vivek already covered this. This is the only slide I'm going to show, just because I think it summarizes not only a catheter, but the system that this study represents, which includes the mapping system, PF-RF generator, irrigation pump, and a dual energy catheter that can do it all, map and ablate using two modalities of energy. And what are the potential advantages of a system like this, particularly when you want to compare it to the standard of care in practice? So the large footprint creates larger lesions with improved linear continuity and transmurality. And I think one way to illustrate this, and we've actually generated this many years ago while designing this technology, is that as compared to a small tip catheter, when you use a large compressible tip, you make not only larger lesions, but most of these lesions overlap better compared to a small catheter, allowing you to achieve continuity at higher confidence and ease. It's a focal catheter that allows you to perform any desired lesion sets for any different arrhythmias. The dual energy increase the safety and flexibility, and the ability of a single catheter to combine mapping and ablation improve the workflow efficiency. So let's move on to the trial. So the Sphere-9ᵀᴹ IDE study, the aim of this study was to compare the Affera Medtronic mapping and ablation system to CARTO 3 with STSF for treating patients with persistent atrial fibrillation. And this was a multi-center randomized patient-blind clinical trial. It had a non-inferiority design where subjects were followed for 1 year post-ablation with office visits at 1, 3, 6, and 12 months, and EKG was done at 3, 6, and 12 months. Holter monitors were done twice yearly, and TTMs were obtained at least once a month. But in addition, if patients had symptoms, this is all common in studies like such. The study also included an independent rhythm monitoring and imaging core labs, and there was an independent DSMB and CEC committees that adjudicated all clinical events. So what were the interventions? So the study required high-density mapping of the left atrium with both technologies. With the Affera system, that was achieved using the single Sphere-9 catheter for mapping and for ablation. In the control arm, that required, in addition to the STSF, a separate multi-electrode mapping catheter, such as the Pentaray or the Octaray or a Lasso, whoever like to use Lasso, to also obtain high-density map of the left atrium. The main objective of the study was to achieve a wide area circumferential PVI and to assess the durability of this PVI following a 20-minute waiting time, while operators had the chance to do what we often do clinically, is to use adenosine or isoprel instead of the 20-minute wait time. Now note that because the Sphere-9 system was also allowed PFA, so ablation on the posterior wall or close to the phrenic nerve were exclusively done with PFA in the investigational arm. The study also called for ablation of documented macro-reentrant circuits like typical atrial flutter. However, the study discouraged applying empiric lines that there's no data that they're helpful. Yet, the operators retain the freedom to adhere to their standard of care of their AF patients. But the hallmark, the mandatory part of this study was wide circumferential PVI for both arms. The inclusion criteria included patients with symptomatic persistent atrial fibrillation that was documented by at least 2 EKGs taken more than 7 days apart, showing AF, or by a Holter monitor that shows continuous atrial fibrillation. Patient also had to fail at least one class 1 or class 3 antiarrhythmic agent. Exclusion criteria were common patient with AF lasting more than 12 months, a BMI greater than 40, a massively enlarged left atrium, and an ejection fraction below 35%. The primary effectiveness endpoint was the composite of freedom from failure to achieve PVI and complete all the ablation with the assigned device, recurrence of any atrial tachycardia, atrial fibrillation lasting more than 30 seconds after a 90-day blanking period, any repeat ablation at any time, initiation or dose escalation of class 1 or class 3 antiarrhythmic drugs. The primary safety endpoint was the incidence of pre-specified device or procedure-related serious adverse events. Secondary endpoints included superiority of the investigational device in terms of effectiveness, efficiency measures such as ablation times, and quality of life measures. The study also included a neurological sub-study to assess for silent strokes. So this is the subject flow chart. This study recruited patients from December 2021 to December 2022, and a total of 432 patients were randomized 1-to-1 to the investigational arm and the control arm. After randomization, but before ablation, there was a trivial number of dropouts in both groups. After the ablation, there were 3 dropouts in the investigational arm and 9 dropouts in the control arm. Note that there were 2 deaths in the investigational arm and 2 deaths in the investigational arm and 3 deaths in the control arm. However, all of these deaths were adjudicated and they were not related to the procedure or the device. So this study was conducted across 23 sites in 3 countries that included the United States, the Czech Republic, and Israel. and the study was done by a relatively large number of operators, 40 operators. The compliance follow-up rate was also remarkably high in both groups, exceeding 90%. So who were the patients? So the mean age was 67. In the investigational arm, there was a slightly larger proportion of females. Patients had mildly enlarged left atria and a mildly reduced ejection fraction in both arms. The majority had hypertension, 75%, and a substantial minority had diabetes and renal disease. So let's turn into the results. So the primary safety events occurred at a very low rate in both groups. In the investigational arm, that was only 1.4%. In the control arm, that was 1%. Importantly, there were no events of permanent phrenic nerve paralysis, no strokes, no perforations or tamponades, no fistulas. And this small number of complications were driven by increased duration of hospitalization or readmission, usually due to COPD exacerbation or heart failure exacerbation, but really not related to the device. The study concluded that the investigational system was non-inferior to the control with this p-value. In the neurological sub-study, the rate of silent strokes was very low in both arms. Importantly, in an MRI that was done 90 days after the ablation procedure, it showed resolution in all but one patient in each arm. And this is in line or better than previous reports. What about effectiveness? The primary effectiveness success rate was 73.5% for the investigational arm and 65.2% for the control arm. The investigational arm was non-inferior to the control arm. Now, if we dive more into those results, we can see that the difference in effectiveness between the investigational and control arm was 8% in favor of the investigational arm. If you look on this graph, you can see that the curve here, it's just shy from meeting superiority. Actually, if one or two patients were more successful in the investigational arm, that would have reached superiority. Overall, the study did not reach superiority. It was not designed to reach superiority, but it highlights the significant improved outcome with the investigational arm. This table details the results, including the mode of failures. Importantly, in the control arm, there are two events where when ablation with Thermocool was unsuccessful. In one case, the operators were not able to isolate the right superior pulmonary vein and reverted to use a cryoballoon. In the second case, they attempted to create a mitral line that was unsuccessful and resorted to inject alcohol into the vein of Marshall. In terms of efficiency, the investigational arm required 1/5 of the ablation time compared to the control arm. It also required a significantly shorter transpired ablation time from first to last lesion. And overall, the skin-to-skin procedural time was also shorter. Now, take into account that most of the operators participated in this study were highly experienced operators with the control arm, but they on average treated only 6 patients with the investigational arm, and that speaks for the ease of use and the rapid learning curve with the investigational arm. I would like to share with you a case that was provided to me by Musa Mansour, but it's a common case that we see in clinical practice, and in this case, after completing the PVI, program stimulation was done and induced a mitral flutter. You can actually see the slow conduction across the anterior septum here. The operator chose to create an anterior mitral line, given that there was slow conduction in the anterior wall. That only required 7 applications with 35 seconds of ablation. He then used the same Sphere-9 to check for block across this line by mapping not only the left atrium, but the right atrium, and show that the line was blocked. Few more slides about efficiency with this catheter. So because this is an all-in-one catheter for mapping and ablation, in the vast majority of patients, only a single transeptal puncture was done. In the control arm, 62% were done with a single transeptal, where in 38%, the operators chose to do another transeptal puncture and introduce the second catheter. But remember that even if they did not choose to do a second transeptal, they had to exchange the catheter between a mapping catheter and an ablation catheter, at least twice during the case, where you did not have to do catheter exchange at all with the investigational arm. What about other parameters in this study? So the fluoroscopy dose was low in both arms, slightly lower with the investigational arm. The time from the beginning to the end of the PVI was significantly shorter, almost half, with the investigational arm compared to the control arm. The total fluid delivery was also shorter, almost half as well. What about other lesions, other lesion sets? So operators, again, the mandatory part of the procedure was PVI. The rest was operator discretion, how they treat their patients with atrial fibrillation, and the strategy was similar between the two arms. So you can see that the majority of patients in both arms underwent something more than PVI plus. In the control arm, that was 85.6%. In the investigational arm, that was 95.8%. CTI line was done in nearly half of the patients in both groups. Roof line and posterior line or posterior wall isolation were done more commonly with the investigational arm compared to the control arm. And even a greater difference was made with the mitral line. Now, why that was done? That real world in some way. The operators had the choice to use a tool that probably they felt more comfortable using. But what I did not show here is that we did some analysis to see if any of those lesion sets have translated or altered the results. And what we found was relatively similar to most of the publications in the past, including STAR-AF, that the addition of any of those lesion sets did not impact the clinical outcomes. And PVI was the lesion set that had the most significance on clinical outcomes. What about quality of life? Quality of life improved with PVI in both groups to a similar degree. And to summarize, the Sphere Persistent AF IDE study is the first RCT to investigate PFA in patients with persistent atrial fibrillation. The trial examined a new mapping and ablation platform that integrates high-density electro-anatomical mapping system with a focal dual-energy ablation catheter that has a large footprint electrode. The investigational system was non-inferior in terms of safety and effectiveness. It was superior in terms of procedural times. And we also need to know that the potential benefit of additional lesion sets beyond PVI was not part of this study. And if that's going to impact our outcome with patients with persistent atrial fibrillation, that should be addressed in a dedicated, well-powered study in the future. And I'll end here by thanking all the principal investigators in all sites and all the folks that participated in the monitoring committees. And I'll hand it back to Khaldun. Thank you.
Elad, thank you so much, and really congratulations to you, to Vivek, to Musa and Devi, and all the principal investigators that you shared with us on the screen. It's really a remarkable trial. I think you mentioned it that the outcomes it's the testament on both sides, on both arms, to be honest with you, just a testament about the quality of care that we are providing for AFib patients. So to come in the randomized trial with a new technology and meeting the outcomes with non-inferiority, this is not was designed for superiority, yet it's really remarkable and a testament to you and all the investigators and the quality, including the coordinators and our team. The study was done enrolling in less than 1 year again, really remarkable effort with a small team. So with that, I'm going to start with give you a break a little bit, Elad, and thank you for a fantastic summary as well. And I'm going to ask Devi a question. Elad mentioned the slides that the average number of procedures per operator with Affera was about 6. Now, Vivek, we might be biased, but Vivek has been involved in Sphere-9 and Affera, did a lot of preclinical work, was the leader of the European study, same as Elad. I believe Affera was a new system for you. You're very experienced with other technologies as well. So can you tell us a little bit more about that learning curve with Affera and Sphere-9? And if you reflect back, what does that look like, that transition?
I think I will echo what Vivek said. Until I used that catheter the first time, I didn't realize how easy that catheter was. I would say the learning curve is, truly one case if you are a point-by-point ablator to begin with. And, I use RF systems on a regular basis. So the idea that you could just have a single transeptal and not have to exchange anything was really good. I also am a big advocate of not using fluoroscopy. And, Vivek showed in his slide how echogenic that catheter is on ice. So it's very easy to see that catheter on intracardiac echoes. So once you're in with your transeptal, with your routine transeptal sheet, like I used a deflectable sheet in my cases. The catheter itself is very easy to maneuver. The lesion sets, the contact assessment was on ice, but also as you deliver those lesions, when you see the little thermal energy pattern on the catheter and on the side, it tells you whether your lesion was good. So there's a lot of things that was very simple and very easy to kind of, I guess, learn. So I think it was very, very quick. So I would say that every case, by the time it was a second case, it was like, okay, I got this.
Got it. And Devi, I'm just a quick follow-up as well. You led many of us, and you led the field basically with minimizing, if not eliminating fluoro. You talked about a lot of features. Does that system help you with all those added features to excel and continue doing what you like to do, which is no fluoro?
Absolutely. I think I think not using fluoroscopy or minimizing fluoroscopy is something you learn over time. But I was already doing that, and I would say, anytime I use a new technology, I'm always trying to learn the technology and not minimize fluoro. But this particular catheter, I have to say that I didn't use fluoroscopy even in the first case, because you could get across and you could see the catheter very well on ice. You had many things that told you whether you had contact, whether it was ice or on the mapping system as such. I think to me, what was phenomenal was just you did not have to exchange anything. So there was because it's a large footprint lattice catheter. It's very rare that you would not actually lose your transeptal, because that always acted as a bumper. So even when you were kind of in the septal area, you did not have to ever worry about losing transeptal and things like that. And then in addition, you could come in and you could do your map, you could start ablating, and then you could do your remap and you're done. So you didn't have to exchange anything. So to me, it was greatly advantageous for sure.
That's great. And on that note, David, I'm going to turn it to Musa. And, I really like the video that Elad shared. That was a case of yours. It brings the reality of what we encounter, especially with persistent AFib patient. There are certain things that are planned, certain things that you encounter. if I'm going to take those comments about the all-in-one catheter, and I'm trying to embed also a question that came from the audience, this all-in-one that you can map and ablate, how did that change the way that you think about performing these procedures? And the combination of PF and RF, how does that help you in the era of PF? People can challenge, well, why do we even need RF? Is that really necessary? So maybe I'll start with the all-in-one, how that changed your approach to the procedure, and also is RF dead, or do you still see value of the combination?
Yeah, thank you, Khaldoon. I mean, listen, I enjoyed using this catheter a lot in the study. We did a lot of cases with it. And I think if you want to summarize this catheter in one word, you say how versatile it is. And you can do anything with it. You can use it for pulse field, so it is safe in the areas where you need to be safe. You can use it with radio frequency energy in some areas that I will talk about in a second, where RF energy has little more advantage. You can map very effectively with it and very quickly, and you can pace with it as well. So it is truly all-in-one catheter. What we saw in this study and what we saw in general with pulse field ablation, and this is something that we still need to understand, is the rate of conversion from atrial fibrillation to atrial flutter, whether it's typical or atypical, is more than what I'd previously seen with prior ablation technologies with thermal energy. And we have many patients, more than in my clinical experience, more patients who change into either mitral isthmus flutter or tricuspid or CTI flutter. And when you have this catheter, you can quickly create a map of the arrhythmia and you can ablate it with the same catheter. You don't have a single short-shaped catheter where you will be forced to either use the catheter in an area that it's not made for, or you have to open another catheter. So versatility is a very important feature of this catheter. Talking about RF versus PF, I don't think RF is dead because it has some features with a catheter. It has some benefit in a catheter that can toggle between the both, and that's very helpful in two areas. One of them is the CTI line. So before I talk about ablation of the CTI line, it's important to note that the RF lesion with this catheter is only 5 seconds, correct? So it's only 1 second more than the pulse field ablation. So it's really not much longer than it. And also in the slides that Vivek showed earlier about the surface area that you can ablate with this catheter is like 10 times more surface area that you can get with this traditional focal catheter, like 227 square millimeters compared to like 35. So in the patients where we did the CTI liners, you can do it in 4 or 5 ablation lesions. You will be done with the CTI line. And it's, in my opinion, it's better to do a CTI line with RF because you don't have to worry about vasospasm, and you don't have to give nitroglycerin. Another area where RF could be helpful instead of pulse field is ablating in the roof because of denervation of ganglionatic plexi. I think I know it's a controversial issue. Some people believe in it, some people don't. But even if there's a small possibility that can help, doing that area with RF may add to the success of the procedure. So to summarize, it is versatile, and the ability to deliver RF and PF could be helpful in different areas of the heart.
Thank you, Musa. That was a great summary. And the recommendation are very clear right now about PF is exclusively on the posterior wall. That's the only thing we use. But all these decisions are really driven by the mindset of safety. And I think there's a lot to be learned, like you alluded to the new knowledge about coronary spasm. You could just switch to RF. And I believe in the European data that was published and Vivek showed us, the average time for CTI line was 2 minutes. And that's also including some that were done with RF. Elad, there's the many questions that came, and I think you're probably the best person to answer this. You did a lot of work on the biophysics of RF. Musa mentioned it briefly. This is temperature controlled. If you can explain to us a little bit more about the concept of the current density and why that is advantageous. One common comment that we hear about Sphere-9 that you rarely get, if any. I personally have never heard about the steam pops. Never say never. We know this in EP, but it's really unheard of. But can you explain to us the RF component, the temperature controlled, the 5-second lesions, and the concept of current density?
Yeah. So yes, again, like I'll start from the end. I never experienced, I don't think anyone else on this panel showed the steam pump with this catheter, either preclinically or clinically, like we don't. And that has to do with current density. Now, you probably can recall that none of us spoke about current density up until a few years ago. Like we didn't even know what it is actually. We heard about it, never used it. We started using this when the concept of high power short duration came into play with different catheters before Affera. The 90 watts, 4 seconds, and other catheters, 70 watts for 6 seconds. And then we started to see like this era that we wanted to make transmural lesions quicker. We saw that there is a very narrow therapeutic window, meaning that you have a very narrow window between getting transmural lesions to having a steam pump. So 9 watts for 4 seconds may give you transmural lesion, but 9 watts for 6 seconds will give you a pop. And then we started looking into what is this whole current density issue mean? And what current density means is that it's how much of the surface area of the catheter is in contact with the tissue where current comes out from. Basically, the current that you deliver from the generator, how much tissue it spreads to. So because the 3.5 millimeter catheter has a relatively small surface area, it's in the range of 28 square millimeter, but there is actually great work that was done by some engineers that show that at all times when you ablate, when you do a PVI, between 5 to 20% of the surface area is actually in contact, more 5% than 20%, depends where you are. So you apply a lot of current through a very small surface area, and you can overheat the tissue and create a pop. Now, the Sphere-9 is a whole different way to think about an electrode. In one, it's the surface area, the effective surface area of the entire lattice structure is 275 square millimeters, so it's 10 times as much. It's compressible, so it allows you to be in contact with tissue in more optimal way compared to a solid metal tip. So just by the difference in the surface area and the compressibility, you are more likely to have more tissue in contact. Second, the generator apply energy in a temperature limited fashion, meaning that it uses the thermocouples, the feedback from the thermocouples on the surface to decide how much current to deliver. And if you reach a temperature that can be 70 or 73 or 75 degrees, then it titrates the power down to avoid the steam pump. So all in all, you have a hardware that is more suited to have a greater surface area in contact with tissue, and you also have a platform, a software, and a generator that can give you constant feedback to avoid overheating. I hope that explains the question.
I think that was great, Elad. And there are a couple of questions that came. It's always a good reminder. I'll try to answer those because I have one for Vivek as well. There are 9 electrodes on Sphere-9 are for signal acquisition and annotation, but they're also thermocouples. But when you apply the energy, it's applied throughout the whole lattice. There are always questions that they come. And for PF, it's monopolar. It's biphasic. All PF technologies are biphasic. It's monopolar, so it's from the sphere to a patch, which is different than other technologies. There are 2 questions. I'm going to combine them, and I'll turn it to you, Vivek. We see that it's all in one. You map and you ablate, and we all heard about the great features about the sphere, stability, and the advantage of RF and PF. But are you compromising the quality of the mapping? You mentioned it briefly, the acquisition is unique. It's what we call close unipolar. Can you tell us a little bit more about the signal acquisition and the quality of the mapping you generate? We saw some beautiful pictures, but would love your opinion as well.
Yeah, no, I mean, this is a big advance in quality of mapping. Remember, while that whole ablative surface, while that whole lattice tip is ablative, the electrograms are not derived from that whole lattice tip. They're derived from those individual nodes, which are very, very small mini electrodes. So, and they're relatively orientation independent to the wavefront because it's a bipole between that node on the surface and the central electrode that's sort of internal next to the saline irrigation nodule. So actually, the quality is much better than what you're used to, at least using a typical ablation catheter. The fact that it's a single catheter that provides both the ability to identify with high fidelity these electrograms, the location of, let's say you're doing an atypical flutter, for example, you identify it and then can deliver with the same catheter without having to manipulate another catheter through the transeptal and get to that some location. I think that's fantastic. So yeah, I'm sorry if I wasn't as clear when I presented initially, but the fact is, this is about as high quality, I think, in terms of mapping as one can expect. Was there a second part of that question? I can't remember.
No, that's all. Actually, there is another question that I'll maybe you can follow up, or I'll open it up to the rest of the team. It's actually a good question. Does the system deliver the energy even if you are not in contact? I think what we didn't touch base about, well, you don't have contact force, but there are some indicators for contact. But does the system deliver the energy if you're not in contact? Or does the feedback from the system that you get, whether you are delivering energy without contact? So maybe I'll ask you, Vivek, to continue.
Yeah, just I didn't get into this. You're right, but there is electrical impedance-based contact sensing, and because it's based on those very small mini electrodes, it's actually pretty good quality. You can tell when you're touching tissue based on that. By the way, you can also tell when you're touching tissue because the catheter is touching tissue, touching your perceived surface. It's amazing how you don't miss the lack of contact force at all with this technology. But specifically in terms of feedback, with RF, it's very easy. When you're delivering energy into tissue, if you're touching tissue, you see the blush of heat as the tissue gets hot. So it's very, very simple, actually. With PF, and this is what I started to allude to a little bit, you actually do see some degree of elevation of the temperature. And I think that provides a good feedback that you're actually interacting, that the electrical field, I should say, is interacting with the tissue. And again, the amount of elevation is not very high, but you're going to get something. I mean, you can't dump that much energy in the tissue and not, see some sort of thermal effect. So yeah, actually, that is a feedback. What's the right amount of blush that you want to see for a lesion? I think, the system actually has some internal sort of filters that sort of tells you, okay, this is a reasonable quality lesion. And I think that, with additional clinical experience, that'll probably be refined further.
Yeah, and maybe also, and you mentioned it in the presentation, you showed that red color lesion, these are the RF, and the green color, the PF. And I always say you need to earn the red color and the green color, because if you don't get that temperature rise with RF, or even with PF, those will be gray color. So another way of feedback whether your lesion is truly effective in contact with the tissue or not. I realize we're on time. I mean, this is a fantastic session. A lot of questions came. Like one, I'll address briefly, whether we measure esophageal temperature or cool the esophagus during these cases. I think it's all in the paper. The use of esophageal probe was optional, and some, to gain confidence, they used it, but there was no esophageal temperature rise to be concerned about. And as Vivek mentioned, in the study in Europe, we actually had an EGD study that was also very reassuring. So fantastic talk. As you can see, a lot of excitement, fantastic trial. Thank you, Vivek. Thank you, Elad. Thank you, Musa. And thank you, Devi, for a beautiful conversation. And clearly a lot of questions that remain to be answered. Now we have the tools. We have a lot of homework to be done. with the advantage of additional lines or RF, MPF, a lot of exciting things in the field. So for our audience, maybe the team can scroll the slides. Please submit your survey, and you're going to get the feedback for the survey in the Q&A. And thank you so much for attending late in the US and hopefully globally as well. And this will be hopefully provided on Medtronic Academy for on-demand viewing as well. Thank you for all our speakers, and thank you for the audience and Medtronic team, and see you in the next scientific exchange.
Thank you.
Thank you.
Thank you.